start. Well, welcome everyone, and a special welcome to our two guest speakers tonight. Associate Professor Michael Stubbs. Michael is an oral specialist out of Melbourne, and our sleep physician, Dr. Linda Schachter. So welcome, Linda and Michael, and thank you for your time tonight. My name's Peter Field. I work for TDSA. I am the manager for New South Wales and the ACT. And TDSA is a dental lab, and we are happy to work in conjunction with the Respiratory Dental Institute to bring you this series of seminars, webinars, and we hope to continue every month with a monthly update. So thank you one and all for coming. Tonight we're going to do two case studies. I would ask everyone to mute their computers for the time being. If you have questions, actually there's only a few of us, so if you have questions, you might like to unmute your computer and ask a question. I think that'll be quite acceptable tonight. We've got two case studies, and I'm going to pass straight over to Michael to introduce our first case study. Bear with me while I share the screen. I'll be right there. So this is the mild patient.
Thank you, Peter. Anyway, the beauty about this approach is that we just have to go to the first slide.
Yep.
The beauty of this approach is that both Linda and myself, who actually work with mutual patients, would like to share how we assess a patient, how a sleep study is organised and interpreted, what data they look at, and then how do we manage that patient. So the first case we did was a mild obstructive sleep apnea patient. Next page. Miss PW was a 21-year-old lady who, actually 22, who by definition was not considered to be overweight. Her body mass index ratio was 22.4 kilos per metre squared. And as we know, between 18.5 and 24.9 is normal for BMI. And when you look at the medical history forms associated with this patient, she wasn't prescribed any medication. She didn't have a history of any respiratory disorders such as asthma, but did note the fact that she suffers from allergic rhinitis or hay fever. Her chief complaint really was the symptoms of snoring and a sense of being unrefreshed on awakening in the morning. So as you can see in the clinical photograph on the right-hand side of the slide, she has quite a long, slender face. If you have a look at the actual mandible, you can see it's quite a steep mandible. And asking some questions about a TMD or temporomandibular disorder assessment questionnaire that we use, the patient did not have a history of any stiffness or pain associated with her jaw, either on awakening in the morning or when she was chewing food. There was no also history of any locking of the mandible and no trismus or limited mouth opening. But the intermittent nature of the blocked nose was noted. And clinically, on examining the patient, her temporomandibular joints and muscles of mastication, masseter and temporalis, were both not painful to palpation either. So she basically presented as a case where there was clearly no pain or restriction in the ability of her jaw to move. Basically, on getting her to close one nostril and try breathing in the other one and so on, she did have partially obstructed nasal passages. Maximum mouth opening was 38. We know that 36 to 52 millimetres is the normal range. She had an 8 millimetre lateral excursion range, which again, 8 to 12 millimetres, quite normal. And she had a protrusive mandibular range of 6 millimetres, low end of the normal range, 6 to 8 millimetres. Next slide. As you can see on the top right-hand side of the OPG radiograph, there was clear evidence that the condyles, both left and right, were quite sound. They slight interesting, people or colleagues often assume that the condyles must look symmetrical when you look at an OPG, but they don't necessarily have to. Mother Nature doesn't always make the condyles obviously the same shape. And I think the importance of this, noting this comment, is that the OPG is a one view of the TMJ joints. So we often recommend opening and closing, what we call transcranial views of the TMJ as well, just to get a little bit more 3D perspective. We can identify clearly there are two unerupted mandibular third molars, but otherwise both the appearance of mandible, maxilla, and the teeth themselves are quite sound. If you have a look at the lower aspect of this slide, you'll see an image of her tongue and the soft palate. This is defined as a Friedman tongue position type 2. That simply means that at rest, the tongue is not considered large, doesn't cover the occlusal surfaces of the teeth. And you can clearly identify the palatal arches, but you cannot see the tip of the uvula. So clinically assessing this upper airway, we have a patient who has a steep mandibular plane, doesn't have a large tongue by definition in regards to the volume of space in the mouth, does not have an underlying temporomandibular disorder, both historically or clinically, and does not have a long soft palate. So we took the liberty of referring this patient off to sleep physician Linda, who then assessed this patient. And I'll pass you over to Linda now, if you don't mind, Linda, sharing with us what you determined.
Thank you, Michael. Now, I suppose the one thing with this lady before we start and before we do a sleep study, if she's currently got allergic rhinitis or hay fever, it is important that we treat it before we study the patient, because we want to know what they're like at their best situation. So if they've currently got symptoms of allergic rhinitis, partial nasal blockage, runny nose, postnasal drip, itchy eyes, or whatever, it is important to treat them. The way that we treat them is with nasal steroids as the first line, and there are some really good nasal steroids currently available over the counter. Probably the best one currently available over the counter is mometasone or Nasonex, and that's actually 50 micrograms, and it's one spray each nostril, nocte or daily, whichever works for the patient. A very small risk of a blood nose with them. And what we normally do is the maximum effect is at the 4-week mark. So we would delay the sleep study for 4 weeks to make sure that you've got optimal nasal patency for the sleep study itself. Okay, now we're going to go through the sleep study itself. So when this is a type 2 or home-based polysomnogram that we're looking at here, what we do is we look at the sleep stages, as you can see here. The red is REM or rapid eye movement sleep. The yellow here is stage 1 non-REM or dozing. Green is stage 2 non-REM or light non-REM sleep. And this turquoise colour here is the pooled stage 3 and 4, deep non-REM, or what was previously called slow wave sleep. And as you can see here, there are cycles of sleep where people go through light, deeper, light, and then dream sleep. And we all go through 1.5 hour cycles overnight. And as you can see, the proportions of each stage of sleep do vary slightly throughout the night and do vary depending on the age of the person who's doing the sleep study. You can see here, there's a little bit of fragmentation, a little bit of wakefulness throughout the night, and that's fairly normal when you're doing a sleep study either at home or in hospital. This is the body position, and most people change body positions about 6 to 7 times overnight. It's very rare for somebody to be in one position for the whole night. And if we have a look, this person started on her front, went on to her back, right side, back, front, back, left side, back, right side, front. So she's got a little bit more position changes than normal, so a little bit of restlessness. Again, hard to know if that's the actual doing the sleep study itself. Now, when we look at respiratory events, we actually divide them into apneas, so cessation of airflow for more than 10 seconds, and then apneas are subdivided into obstructive apneas, so there's a cessation of airflow with respiratory effort, a central apnea, so cessation of airflow with no respiratory effort, and then there's a mixed apnea, which is a combination of the two. We also look at what's called a hypopnea, and a hypopnea is a reduction in airflow of more than 50% for more than 10 seconds with an associated arousal and drop in oxygen desaturation, usually 2 to 3%. And then there can be unsure, and then what are called respiratory related arousals. So what are the previous sub-criterion events? So they don't quite fulfill some of the other criteria, but we can see that there's an arousal related to reduction in airflow. And usually what that means is there's no oxygen desaturation. And as you can see with this lady, there are runs of hypopneas throughout the night. Most of these hypopneas line up quite well with the REM sleep. If we look at the snore signal here, we can look that she's actually got quite loud snoring. It is intermittent throughout the night, but essentially loud snoring throughout the night. Now, if somebody's complaining of loud snoring and you don't quite see it on a sleep study, it does vary night to night. And then we get an oxygen saturation. Now, most people are between, what we would like them to be is between 90 and 100% for the entire night. But you can see here with these events, you can see these short desaturations with those events. Then we get the statistics. Now, less than 5 respiratory events per hour of sleep is considered normal. 5 to 15 is mild sleep apnea, 15 to 30 is moderate sleep apnea, and over 30 respiratory events per hour of sleep is considered severe sleep apnea. So we're going to start with the respiratory events per hour of sleep. And it's usually in most of these reports, it'll be divided into non-REM and REM, and then given an average for all sleep. You'll also get a supine, other, and then average for how much the patient spends in each position. So if we look at this lady, non-REM sleep, her RDI in the supine position is 14.1 respiratory events per hour of sleep. In the non-supine position, 5.7, and then dependent on how much time she spent in each position, in non-REM sleep, that's 7.5. In REM sleep, it's 18.7. So overall, her AHI or RDI, respiratory disturbance index, is 10.3 respiratory events per hour of sleep. Now, if we look at this for this lady, she's got mild obstructive sleep apnea. It's worse in the supine position, so 16.4 respiratory events per hour of sleep, the supine position, and a bit worse in REM sleep as well. But overall, mild obstructive sleep apnea. If we look at the duration, the average duration of these events is 26 seconds. And you also get statistics on the oxygen desaturation. You'll get some sleep statistics, arousal statistics, and then some sleep, how much sleep the person had during the study. So if we're looking at the raw data, this is 5 minutes. So the top two are ECG and EEG. So this is raw data from the study itself, and they're 30 seconds per screen. Below SpO2 here, down here is 5 minutes per screen. And you can see here, this is the airflow or nasal pressure. And you can see here the vibration at the top. Normal breathing looks like a nice sine wave. So the fact that we've got this vibration at the top of each breath tells us that the patient has flow limitation, and it also tells us that the patient's snoring. And as you can see here, thoracic and abdominal are nicely in sync without a lot of variation. And we've got a snore signal here, which shows noise with each breath, and sometimes quite loud noise. This one is actually showing the variation in airflow. So these are the hypopneas or reduction in airflow of more than 50% for more than 10 seconds with the drop in oxygen, 97 to 93. At the end of it, the person takes deep breaths or maybe gasping or choking, and then they'll take another few breaths and then have, and often there'll be runs of these hypopneas. Here, a reduction in airflow, then gasping again, and you can see here the oxygen desaturation from 97 to 94. And these are runs of what are called hypopneas in this patient. So in summary, we've got a 22-year-old, birthday today, young female who's not overweight, who's got a snoring problem, mild obstructive sleep apnea, which is worse in the supine position. We've got a past history of allergic rhinitis. Michael.
Thanks, Linda. That was really comprehensive. Thank you very much. And because we know that the patient clinically does not have TMD and certainly has a reasonable range of movement of the manual, particularly protrusively, although we always try to achieve a minimum of 5 millimeters advancement potential if we can, to have a better impact on the airway, upper airway, when they have a mandibular advancement splint fitted. The suitability then of this patient for a mandibular advancement splint is actually quite good. And so, next slide, thank you.
Oh, whoopsie, sorry.
Next slide.
Yeah, sorry about that.
That's all right. So, as a consequence, the management of the patient would be in part considering a dental device, because, as Linda highlighted, the difference in position of her apnea events based on her being on her back relative to, say, on her side or sleeping on her front, having a sense of recommending a treatment for keeping her on her side would actually be quite useful as well. And also, as Linda indicated earlier, addressing the hay fever as well. So the combination effort. One of the things that's really important is for people that actually look at the course that's being run by Respiratory Dental Institute, which is a introductory and advanced certificate program to teach you about dental sleep medicine. We do talk about the role of the nose. It's very important in the understanding that can contribute to snoring as well. Next slide, please. And so in context with this case, one of the things we also do and should do is explain to the patient that no treatment has no side effects. And in the dental world, we're talking about the occlusal changes that are commonly seen in patients who have a mandibular advancement splint. Interestingly, most of these occlusal changes occur within the first 6 months to 3 years of wearing the device. And so, as a clinician, one of the things that's important to explain to the patient is that when they have the device made and fitted, part of the follow-up process, which is really important, I usually recommend over the first 6 months, is to make sure that they're getting not just a good result with their snoring, but also making sure that their jaw is comfortable and you get a good perception of how, if the occlusal is changing, is happening. And I also strongly recommend that they then follow it up on an annual basis, just as like you would if you were doing an annual dental examination. So if you have a patient, let's say, who you've made a mandibular advancement splint for, you should encourage them to bring it with them when they do have their annual dental visits, so that you can at least establish the integrity of the device, the retentiveness of the device, the position of the device, and you can also determine if there has been any occlusal change and the extensiveness of that occlusal change.
Yeah, I'd actually just like to comment a little bit on positional devices, Michael.
Yeah, sure.
If this lady, I mean, she only had mild sleep apnea overall, and it was a little bit worse in the supine position, you're going to make her a mandibular advancement splint. So she possibly won't need positional treatment. So I think that once, what you do with her would be make sure her nose is clear, you'd make the mandibular advancement splint, and then you'd reassess what she was like. And then if she needed it, because once you do keep people, positional treatments are still in the fairly basic stages, and people do like to move into different positions regularly. So if you're limiting them going onto their back, you might make their sleep a little bit more uncomfortable. So just to be wary of that. And like I said, she's only got mild obstructive sleep apnea. So I'd wait to see how she was once the mandibular advancement splint was made.
Yeah, look, that's good. That's good advice. And I was going to ask you, Linda, what's your thoughts on, you mentioned about the use of Nasonex,
Yeah.
but some patients are very averse to using sprays. And what's your thoughts on the mutes made by Rhinomed? Do you advocate for them, or do you see them having a role in helping a patient keep their nasal passages open?
Look, mute is for those who don't actually know what it is, it's an external nasal dilator. So it's put into the nostrils at night and it keeps them patent. I actually think that mute is actually particularly helpful for those people who tend to have quite a collapsible nose during sleep, or someone who has very narrow nasal passages, rather than someone who has allergic inflammation of the nasal passages themselves. So yes, I do think mute can be quite helpful in the right patient. It's actually not particularly expensive. It's worth giving it a try if they've got a problem. It's available from pharmacies, and like I said, it's called an external nasal dilator. So it may be worthwhile to try, or it might be useful in conjunction with other treatments. So it does depend on the nasal passages, if they're narrow, if they tend to collapse. And so yes, I do think they're quite helpful. If somebody has allergic rhinitis and doesn't want to use a nasal steroid, I would then maybe recommend trying an antihistamine, but that's actually only a symptom control. It doesn't actually deal with the problem itself.
Yeah, look, thanks, Linda. The other thing I was going to say too was I often use the mutes too in cases where, as you say, that they don't have just allergic rhinitis. It's more about nasal obstruction or collapsing of the nose. But also in patients who have the trial device, a trial dental device, sometimes we can introduce a mute as well. And they come in a trial pack, small, medium, or large size, which is actually what I would advise colleagues who are recommending them to suggest to the patient. So they get the right size dilator for the patient's nose. And you can find, it's interesting, there is a great app called SnoreLab. And SnoreLab is a very accurate recording mechanism which they download. It's a free download on the phone, and you can actually use the mutes to see if that impacts on snoring, and then the patient can go ahead and have the trial device made, which we talk about in our training program, and they can see if there's an improvement in their overall well-being just by trying these two simple approaches.
Yeah, look, I think that's really good. The one thing I wouldn't recommend is a decongestant. Obviously, a nasal decongestant more than 2 to 3 nights per week really is likely to have rebound rhinitis. So that's a real problem if they're using a decongestant. So if they don't like a nasal steroid, there's actually a new nasal steroid combination with a antihistamine that's been released in the last couple of years that actually does give much quicker symptom relief. I don't know, it's Dimista, so that actually gives very quick symptom relief, and most people, it's a BD dosing, and most people get symptomatic relief within about 4 to 7 days, so much quicker than nasal steroids, which really do take up to 4 weeks to get symptom control.
Okay, that's really helpful. Thanks. That's great. That's very interesting. Now that needs a script though.
That does need a script. Yeah, I'm not really quite sure why, considering it's a lower dose steroid and a low dose antihistamine. But at this point, it does require a script. But you can actually tell your patients to go and get one from their local doctor, and it's called Dimista. So, like I said, low dose steroid and low dose antihistamine, and a much quicker symptom control. So it's within 4 days that people start noticing symptom improvement.
Great.
Thanks, guys. Yeah, I'll stop share and I'll go to the next case study.
This was an interesting one, actually, Peter, for a number of reasons, as we'll see when we start talking about the case.
Let me move that up a little. There we go.
This is a patient to whom presented.
Hang on 2 seconds, Michael. It'll take me 2 seconds. Sorry, I've just got control.
There you go.
There we go.
This is a patient, a male patient actually, who again is 20 years old, and he presents with a history of unrefreshed sense of sleep, difficulty concentrating for long periods. So he has a weariness or sleepiness type issues during the day, snoring, and he's also aware that he bruxes. And we know that bruxism, certainly in the literature in the last 10 years, maybe even 15 years, the knowledge and the publications have exploded. I mean, there's over 1,200 review articles alone on bruxism in the last 15 years. And so as a consequence of this, the medical history of this gentleman indicated, again, he had no underlying respiratory disorder such as asthma. He did not have a history of a blocked nose, and he still had his tonsils. So the history of the patient, particularly in reference to his, let's say, temporomandibular complex, is that he didn't have any issues of pain or stiffness or restriction of movement of the mandible either on awakening, which is interesting because he comments on bruxism and the awareness of bruxism. Now, bruxism, for everybody watching, I realise who are dentists, understand what bruxism is, but it's not just tooth grinding. Bruxism refers to clenching and or grinding, what we call occlusal parafunction. And we also realise from the history of this gentleman, no history of locking of the mandible, certainly no trismus, and no difficulties or restrictions when he's masticating. So here we have a guy who is a young man again, like the similar age group of the previous patient, who has tiredness issues, comments on snoring, does not have a painful jaw mechanism, but is aware from comments he's received from his partner that he's making a lot of noise at night, which we would refer to as bruxism. And of course, there's the snoring as well. Next slide, please. So clinically examining him, again, he did not have any pain on palpation of either the temporomandibular joint or the muscles, mastication, masseter or temporalis. And he had a pretty reasonable mouth opening, actually, 43 mil. Again, 36 to 52 is normal. Quite reasonable lateral mandibular excursion range of 10 millimeters. And his protrusive range of his mandible was 8, which again is certainly within the normal limits. Relevancy is that in this context, you have already evaluated the mechanism of the jaw, his potential range of movement that he has. There's certainly no disability or dysfunction as far as movement or functionality of the jaw is concerned. And given the history of the sleepiness or the tiredness, certainly renders him a suitable patient to discuss with him about having a sleep study done. Next slide, please. So you can see on the radiograph, again, OPG, unfortunately in this image, the condyles have been partially trimmed off in the image. But again, you know, dentally, he's quite fit there. He's got like a rotated canine by the look on 4-3. He has 4 unerupted third molars. Just going back to the previous slide.
Yes. Oh, sorry, Michael. 1 second.
Sorry, was that me?
I'm not sure what happened. I'm not sure how that happened. Oh, sorry about that, guys.
That's all right.
I'm taking my hands away from the computer.
And you can see he has, again, classification, Friedman tongue position. So as dentists, we evaluate the upper airway. He had the evidence of his palatine tonsils, but he did not have a long, soft palate. He did not have a large tongue. So he was then referred off to Linda again to have further investigation for potential sleep apnea. So thanks, Linda, if you wouldn't mind explaining the case.
Yeah, thank you, Michael. Sorry about that with the clicking. Okay, so if we look at this guy's sleep, again, we've got these cycles of sleep and we've got the non-REM, REM cycles of sleep. And as you can see here, they're the classical cycles of sleep throughout the night. This guy's not as restless as the previous lady. We've got him on his back, on his front, on his back, left side, and then front again. This particular gentleman, though, we are seeing runs of obstructive apneas. And as you can see here, there are 3 runs of apneas, and then there are some hypopneas throughout the night. He does tend to snore loudly throughout the entire night. And with these events, we are seeing some desaturations, and he's getting into the high 80% with these events here and with these events here. So if we have a look at his statistics, so again, we can see in all sleep, he has an AHI or RDI, respiratory disturbance index, of 24.9 respiratory events per hour of sleep. In non-REM, it's 22.2, and in REM, it's 33.6. So overall, moderate obstructive sleep apnea, a bit worse in REM sleep, and not particularly worse in the supine position. This guy, again, with his snoring, you can see here a lot more vibration with each breath. And here we've got actually runs. You can see here almost complete cessation of airflow with bigger breaths at the end here. And you can see here, this one's actually 32 seconds. And you can see here the oxygen desaturation of 94 to 90%. And these recurrent runs, so you can see deeper breaths and then shallower breaths. And these is what a run of hypopneas and or apneas would look like in a patient. So in summary, we've got a 20-year-old man with snoring and bruxism. And even though he had some symptoms that showed moderate obstructive sleep apnea. Now, the fact is with symptoms, they don't always correlate with severity. The other thing that it's important to realise is that some of this guy, poor concentration, a little bit of tiredness, may be his symptoms. So he may just be functioning not at his optimal level. So even though he's not presenting with classical really tired or sleepy throughout the day, people can actually, even with very mild symptoms, have more severe obstructive sleep apnea. Thank you, Michael.
Oh, thanks. So the interesting thing about this case, I think, is like the previous one, he's young. Typically people associate sleep apnea with people over the age of 40 or 50. And second, you'll notice the BMI, or they weren't overweight patients. And the third thing, I think, in this case is that one of his chief complaints was the awareness that he bruxed. And it was only through the investigation by not typically saying, oh, well, he's thin, therefore he couldn't possibly have sleep apnea, because we know that's not true. It's because it's about anatomy. He's a narrow airway. But it's more about the investigation process and saying, well, okay, the guy, patient, has a history of tiredness and reported snoring. He was very motivated about that. He also talked about the noise he was making from bruxism. And we know that bruxism is sympathetic overdrive following an apnea event. Now, we know that also that about 8% of adults actually have sleep bruxism, and not everybody bruxes every night. I mean, that's one of the reasons why it has been a very difficult thing to certainly study, because you can be wired up to have assessment for bruxism in a study, and you may not actually have very much or any much activity at all that particular study night. I was going to ask you, Linda, when we refer a patient for a sleep study, and bruxism is one of the motivating factors for also having the study done, would you mind just explaining what would you do as part of the sleep study to actually give us a better objective assessment of bruxism?
Usually what we do, if bruxism is one of the symptoms that you're actually asking about, is you would actually put one of the EMG leads in on the masseter muscles. So you'd actually want to know what the masseter muscles are actually doing throughout the night. So if you're actually asking about bruxism, you do need special lead placement to actually see if the person is actually bruxing during the night, because it's not a standard where we put one of our EMG leads.
Yep. Thank you. And so that means for people or colleagues watching this, if they're going to refer a patient off through the patient's GP to a sleep physician, so the patient gets the Medicare entitlement, and you're concerned about bruxism, you need to actually make reference of that fact in the referral. So this gentleman was deemed appropriate for the mandibular advancement splint. As I said earlier, he didn't have any underlying TMD. And one of the interesting things too is that when you have younger patients, as a general rule, and this can also apply to older patients, moderate severity apnea is a reasonable condition to manage him with a mandibular advancement splint rather than CPAP. And CPAP is a gold standard treatment for obviously patients who have moderate to severe sleep apnea. The American Academy of Sleep Medicine advocates the use of mild to moderate sleep apnea using a dental device, but it also depends very much on other factors such as oxygen desaturation. And so one of the things that I think that's important to say as a dentist is that we are guided by the sleep physician's recommendation. So when say Linda sends me a report, Linda will often recommend the appropriate treatment, and it might be that the patient has tried CPAP and has not tolerated it, or in her opinion, that mandibular advancement splint is the preferable treatment for the individual. And I think bearing that in mind is a really important consideration when you're working as a team with your sleep physician colleague.
Very good. Okay, guys, that brings us to the end of our 2 case studies. Deborah, I want.
Here we go. We've got a couple of. The other thing I think is this guy had enlarged tonsils, and I think one of the things that we should probably bring up is that may be something worth looking at, because it can be. I mean, his tonsils weren't very enlarged, but if you've got someone who has very enlarged tonsils, it may be worthwhile getting the patient to see an ENT surgeon to actually get them assessed, because removing them may actually be helpful, and may actually in some cases be curative if they're very, very enlarged.
Yeah, good point.
So it's always worthwhile getting an opinion as to what the contribution is. Unfortunately, we can't work out what the contribution of the tonsils is until they're removed, but I have had a couple of patients that getting out has actually been getting them removed has actually been curative to sleep apnea.
And again, you know, that's the brilliance of the sleep physician making the recommendation for treatment, because you'd obviously recommend that as part of your assessment of the patient.
Absolutely. Here we go.
So in this case, the patient was recommended a dental device, a mandibular advancement splint. We started him at about 50% of his maximum mandibular range. So he had an 8 millimeter range. So he was started 4 millimeters from centric occlusion. And again, he was followed up over a 6-month period. He was then and would have been followed up on an annual basis. And again, the protocols of treating patients with mandibular advancement splints is that if you make the device, you have the responsibility of encouraging the patient to not just come for the first 6 months to check to see if the advancement process is happening and working, but also to consider referring the patient back to the sleep physician for a further sleep study, because moderate severity apnea, in fairness, really should be evaluating the efficacy of the device once the patient's wearing it. So yes, the patient will often say things like, oh, the snoring's much better, or I'm not getting any complaints, but that doesn't necessarily mean to say you've actually treated or resolved the sleep apnea. And so communicating with your sleep colleague, writing a letter to say you've received the patient and you've done the dental treatment, as in the splint device for them, and then also communicating with the sleep physician and saying, at this stage, in your view, the patient has been advanced and is ready for a further follow-up study. Most sleep colleagues would say, yep, we'll do another study and we can get some objective data to validate the position is actually the most effective for that patient.
Absolutely. And I usually recommend that these patients are reviewed annually. And the reason for this is, one, to reinforce the importance that the person keeps wearing the splint. So that's obvious, and that the importance of treating their sleep apnea, because one of the things that does tend to happen is that patients, you know, unless they're being reminded by their partner, may actually stop using their treatment. So it's really important that we do follow it up. We do actually put in the how important it is for this sleep apnea to be treated.
Yeah, absolutely.
Now, I'm going to ask a question, Michael. Now, the guy presented with bruxism, the mandibular advancement splints, how well do they control the bruxism?
Well, we know that because bruxism is centrally driven, we can't stop the process, but what we would be doing is, by treating the apnea, we'd most likely reduce the severity of the bruxism. But I think even more interestingly enough, it would definitely protect the teeth. Yes. So I think from a clinical point of view, the advantage of having the mandibular advancement splint is that we'd be able to, pardon the term, kill 2 birds with 1 stone. Now, the other thing that's interesting about this patient is he didn't have TMD symptoms. Now, it doesn't mean to say that TMD is only caused by bruxism, but what we're doing is we're being very proactive, protecting his dentition, but more importantly, also be addressing the underlying health issue, which is his severity of his sleep apnea.
Great. Thank you, Michael.
That's all right. Any questions from the audience watching?
Are you there, Deborah?
Yes,
Well, I was going to say,
I'm still
it would be
here.
so unlike Deborah not to ask a question.
Now, that's because I've got an inquisitive mind.
That's why I said it.
So I'm not lying on the couch now, but I am sitting on the couch in front of the fire because it is Ballarat. So a couple of questions with what Linda was talking about with the bruxism. Some of the appliance designs have lateral dorsal fins and wouldn't allow any lateral excursions. So sort of just putting the patient in a fairly rigid anterior advancement position. Have you used any with dorsal fins, or do you use a fairly free, or do you use the lock-in ones, or the monoblocks? How do you sort of do you sort of allow for that lateral excursion if the patient's...
Well, I certainly wouldn't use a monoblock. I mean, there's certainly a very low cost way of making a device for a patient, but the patient, you're right, has to have lateral mandibular excursions, otherwise they develop TMD symptoms. Most of the dorsal fins, certainly from my experience, you do, and it does allow for lateral excursions because you have the fin relative to the block, which is the adjustment part on the maxillary aspect of the device.
Yeah.
The ones I use, that they vary, but they would either be dorsal fin, Somnomed type device. ProSomnus is another brand that can be used. I don't tend to use the MDSA. Now, the MDSA, which is the previous photograph, do you mind just going to the previous one, Peter? Previous slide.
I think I'm
you're in control, Linda. There you go.
Yeah,
you can see here on the left-hand side is your dorsal fin, and on the right-hand side is the MDSA, which some colleagues still use them actually. I don't, because I find that you can get lateral mandibular excursions. Again, you get a good holding of the mandible in position. It's titrated from the front, but a lot of patients get a lot of pain in the front teeth. And so ultimately, the device that one uses for sleep apnea or snoring must be a two-piece device, in my view. It must enable lateral excursions of the mandible, and it obviously must be titratable. I mean, they're the three main principles that I would follow. And there are probably about, 50 different devices manufactured from different companies. But I think if you have those three principles, then you can actually make judgment calls about what's your best device for your patient.
Yes, and how many patients have you seen that have had irreversible occlusal changes, like into a class 3 situation, which can't be resolved?
99%. 99%
have occlusal changes.
Mm-hmm. And most of them, you see, as you know, premolar open bites around the premolar regions, and you get the retrusion of the maxillary anterior teeth and proclination of the mandibular teeth, particularly incisal teeth anyway, and they become, class 3. That's the problem we have. There are no algorithms yet developed where we can make suitable prediction of the severity of the occlusal change, which is one of the reasons why we do strongly advocate the regular reviews of your patients. And sometimes you don't see those occlusal changes initially, but usually by the 3rd year, you'll start to see it. There was a paper published by Schachter et al. In 2017. They did a review on dental devices and talked a lot about the side effects associated with them. And one of the things they said was that when you do the titration of the device, we know that once that titration process has ceased, despite what some studies are showing, it doesn't necessarily mean that you're going to continue to get occlusal change over an extended period. In fact, you do get stabilization of that change. The big issue is, as a dentist, ethically, it is a bit uncomfortable because, you know, you have a patient who has had perhaps orthodontic treatment, cared for their dentition, and then here we go changing that dentition as a side effect of the dental treatment. And for those patients where we meet them in the first visit, we have this conversation. Sometimes, particularly medically fit patients, you'll probably find more the younger patient might consider orthodontic and orthodontic treatment as an option rather than a mandibular advancement device, which is quite a reasonable treatment suggestion. Again, we know that physiology is such that as they get older, they may still develop issues with their airway, but that's certainly another option for them.
So can I just ask you to define what you are calling titration? Is that putting a patient into that advanced position? Is that what you're calling?
No, they start off in an advanced position. The mechanical advancement of the device, it depends on the device. It could be 0.1 of a millimetre, it could be 1 millimetre each time it's advanced, or it could be 0.4 of a millimetre in advancement, depending on the device. And so that titration process is where we would use criteria such as, has the snoring resolved? If the patient if the patient says no, then we would then perhaps consider saying to the patient, right, we can advance the mandible forward. I show them how to do it. And then we give them a plan of, say, every night for 1 or 2 weeks, depending on what their protrusive range is. So that's why we never start a patient at 100%. We usually start them at about 50% of their protrusive range.
And that's just a little wheel that they, like a maxillary expansion appliance.
That's right. That's
so
exactly
you start
right.
about 50% of what you think, into their full protrusive movement, or
that's right.
their edge, or into their full protrusive?
50% of their full protrusive range.
Okay. All righty.
Now, sometimes some colleagues actually are a bit hesitant about that, and they start the patient at 10% forward. Now, if you've got a patient, let's say, who's got mild sleep apnea, probably 10% forward, if you want to do that, you can from centric occlusion. And then you know that when you advance them further forward, the probability of getting a resolution is pretty good. But if you've got the moderate severity case like the second one, in my opinion, you'd have to start them at least 50% of his protrusive range just to have some impact.
Fantastic.
Michael, thank you. We have one more question too, so I'll hand over to Willem. Willem, would you like to ask a question?
He's muted. You need to unmute.
Yeah, I'm just...
Here I am.
There we go.
Hello.
Hello.
Hi. How are you?
Well, thank you.
Yes, I just wanted to ask basically what, in terms of compliance factors with the mandibular advancement splints, what obstacles have you commonly experienced with patients in accepting the MAS device? Obviously, one set of patients who've worn other devices before are much easier to convert to, say, lateral fin devices or such, and are already compliant and familiar. But I just wanted to know what sort of how to go about that if you are suspect of whether they will be compliant or not, or how to encourage that compliance.
Yeah, thanks, Willem. That's a good question.
Yeah.
I mean, one of the things, first of all, is bulkiness of the device. I mean, that's critical, because if they're too bulky, especially as a general comment, patients who have very small mouth sizes, small dental arches, the last thing you do is put something huge in the mouth. Compliance is pretty challenging. So the first thing I do is ensure that the actual thickness of the rims of the upper and lower device is not excessive. Second, you want to make sure if they've got underlying temporomandibular disorder, or they actually have some pain on palpation of the joint or muscles, you might start them in a more conservative protrusive range rather than starting them at 50%. And thirdly, I always say to the patients, look, it will take you about a week or so to be able to successfully wear it during the night. So there'll be times in the first week or so they'll take them out. Sometimes some patients have issues about gagging. And again, in that context, you can design the device to reduce the extension of the palatal and lingual aspects of the device to give the tongue much more space. And the last thing I'd suggest is that when the patient is using the device, they do experience tooth pain. And it's because, again, depending on the manufacturer and how they're made, they are made to fit perfectly, or they should be. And so I say to the patient, look, it's not unusual to get some tooth pain, but usually it's very short-lived and it does subside. Clearly, if there is consistency about certain teeth, particularly teeth that are not directly in alignment with the dental arch, they usually are the ones where they become sore from the splint. You can relieve space in the device to allow more room for that tooth or those teeth. They're really important, and it's very important in the first 4 weeks if you follow your patient up, because in that context you are not just resolving small issues that might develop, but that lends itself to the longer term compliance of the treatment.
Yes, and just one extra thing with the currently advertised nylon splints, have you experienced anything in this direction? Is it a positive direction that splints may be heading into?
Look, there's some great advantages because they don't tend to break. They also can be made quite minimally small. And the third one is that the disadvantage, I think, is that they can be quite tight. So you're probably going to spend a little bit of time adjusting them. But once you've done that, yeah, they're quite good. And certainly some colleagues make those nylon splints. I don't. As a general rule, I have my own ones I use. But the point is it's about comfort for the patient.
Yeah, an option. Yeah, thank you.
That's all right.
Thanks, Willem. Was there any other questions? No? Well, that would appear to bring our webinar for the evening to a close. Once again, I wanted to thank everybody on behalf of TDSA and the Respiratory Dental Institute for coming along tonight. We have recorded tonight's webinar and we will be putting it on both our websites. So happy for you to go back and revisit tonight's discussion and our case studies. Michael and Linda, thank you so much for your valuable time tonight also.
You're welcome.
And with that, we'll call it a day. Thank you.
Thank you. Good night, Deb.